Hi everybody, welcome to our module on cranial nerves. So the cranial nerves are 12 nerves that have roots in the brainstem or the central nervous system, and they supply the head and the neck and carry out some very important sensory functions. Some of these nerves are sensory, some are motor, and some are visceral, and some are a combination. And things to know about each nerve are whether they're sensory, motor, or both. If they have any special features, we'll talk about those with each cranial nerve and what happens when you have a lesion to that cranial nerve. So we'll go over all of this for all 12 cranial nerves in this module. So let's start by discussing cranial nerve 1, which is the olfactory nerve, and this is a purely sensory cranial nerve and it's responsible for smell. The pathway by which it enters the skull is through the cribriform plate of the ethmoid bone, and we'll see a picture of that later on. It synapses in the olfactory bulb and then it travels to a place called the piriform cortex. And lesions of cranial nerve 1 cause anosmia, which is loss of smell. And you should know that smell is the only sense in the body that does not go through the thalamus. All other sensory information in the body funnels through the thalamus before going to the cortex. Smell is the one exception. Damage to the olfactory nerve is rare, but it can be caused by trauma, sometimes skull fractures, and then there are rare infections or tumors that sometimes damage the olfactory nerve. Second cranial nerve is the optic nerve. It's responsible for sight. It's purely sensory, and its pathway to the brain is into the optic canal of the sphenoid bone. It's not really a peripheral nerve, it's technically an outgrowth of the brain. It arises from an embryonic structure called the diencephalon, and I talk a little bit more about this in the module on neuroembryology. In adults, the diencephalon is the upper end of the brainstem, and it also forms the thalamus and hypothalamus. And important to know that only cranial nerve 1 and 2 are found outside the brainstem. All 10 other cranial nerves are found in the brainstem. And if you have a lesion on one of the optic nerves, you lose sight on that side. So for example, if the right optic nerve had a lesion, you would have total blackness in the right eye. On the other side, you would be able to see okay. The oculomotor nerve is cranial nerve 3, and as its name implies, this nerve is responsible for many of the movements of the eye. This cranial nerve innervates the superior rectus muscle, which moves the eye upward. It innervates the medial rectus muscle, which moves the eye towards the nose. It innervates the inferior rectus muscle, which moves the eye downward. And finally, it innervates the inferior oblique muscle, which superiorly rotates the eye. And I talk about all of these eye movements in more detail in the video in Neurology on Eye Movements. In addition to moving the eye, the oculomotor nerve innervates the levator palpebrae muscle, which elevates the eyelid. And then finally, traveling with the oculomotor nerve towards the eyeball are parasympathetic nerve fibers, which constrict the pupil. These nerve fibers innervate the sphincter pupillae. So although the oculomotor nerve itself does not constrict the pupil, fibers that travel with it do. And therefore, in many forms of damage to the oculomotor nerve, you can also have problems with constricting the pupil. So the classic description of an oculomotor nerve palsy is for the eye to be described as down out with dilated pupils and ptosis, which is drooping of the eyelid. I've shown that here in this picture at the top of the screen. The trochlear nerve is the fourth cranial nerve. It is a motor nerve that is responsible for eye movement. It's actually the smallest cranial nerve in the body, and the reason it's so small is because it only innervates a single muscle, the superior oblique muscle of the eye. The superior oblique has complex effects on the eye, but some of the things it does is to turn the eye down and intort the eye, which means to internally rotate the eyeball. And so these movements are very important for things like reading a book or walking downstairs, things where you need to look down and towards the middle of your visual field. Patients who develop a trochlear nerve palsy will have double vision or diplopia, and the eye on the affected side will be tilted outward. This will make it very hard to look down and in and do things that you normally need the superior oblique to do, things like walking downstairs or reading a book. If you look at these two eyeballs at the top of the screen, imagine that this patient has a trochlear nerve palsy on this side. It will cause this eye to be turned outward like this, and that will give the patient double vision because the two eyes are misaligned. To compensate, patients can tilt their head this way away from the affected side. That will straighten the eye on the affected side, and the other eye is normal so it can compensate and align itself with the opposite side. So what this means is in patients who have a trochlear nerve palsy, their head will be tilting away from the affected side, and that's to compensate for the loss of the superior oblique muscle on the affected side with a trochlear nerve palsy. The trigeminal nerve is cranial nerve 5, and it's got sensory and motor functions, but one of its most important functions is that it's sensory to the face, supplies touch, pain, and temperature information to the brain from the face. It's the largest cranial nerve, and it has 3 divisions. That's why it's called trigeminal. One of them is the ophthalmic, the other is the maxillary, and the other is the mandibular, but normally we just call them V1, V2, and V3. Besides sensory to the face, it's got some other important functions. It's part of the corneal reflex, so it senses touch to the cornea for that reflex. And then its main motor component is mastication or chewing. You can't chew if you lose your trigeminal nerve. So when patients have a trigeminal nerve palsy, the first thing they get is a numb face. The second thing they get is a weak jaw, and the jaw will deviate to the affected side because there's unopposed action from the normal side. And then finally, patients with trigeminal nerve lesions get a very serious and painful condition called trigeminal neuralgia. They get recurrent, sharp, sudden pains in half of their face. This is called tic douloureux, which means painful tic. It's so intense that patients wince. That's where it gets the name tic from. And it can be treated with a very special drug called carbamazepine, which is actually an anti-seizure medication, but it works for trigeminal neuralgia. This is an extremely painful condition, and if you ever meet people who have it, they are miserable. Let's talk about the corneal reflex. So to do that, you touch the eye with a Q-tip, and the touching of the eye is sensed by V1 of the trigeminal nerve. It's transmitted to cranial nerve 7 bilaterally, and what you'll get is blink on both sides of the body. So key points here is that for this reflex to work, you need cranial nerve 5 to sense and cranial nerve 7 for the blinking. The abducens nerve is cranial nerve 6. It's responsible for eye movement. It's a motor nerve. It innervates the lateral rectus and moves the eyeballs out to the lateral side away from the nose. If you get a palsy of this cranial nerve, you get diplopia, and you can't move laterally in the affected eye. And we talk about this in more detail in the neurological eye disorders module. Cranial nerve 7 is the facial nerve. It's both motor and sensory, and it's responsible for the muscles of facial expression. Don't get confused and think the facial nerve is sensory to the face. It's not. That's the trigeminal nerve. The facial nerve is motor to the face. It's also responsible for taste, salivation, and lacrimation. It does some ear muscle innervation. And a special feature of this cranial nerve is that it's got dual upper motor neuron innervation. Let me explain what I mean by that. So the facial motor nucleus in the pons sends out separate fibers to the lower face and the upper face or forehead. So if you have an upper motor neuron lesion from the cerebral cortex on the opposite side of the brain, you will get something that looks like this. So you will lose completely the motor innervation to the lower half of the face. However, the innervation to the upper half of the face has dual supply from both sides of the brain, and it will remain intact. So patients with upper motor neuron lesions of the facial nerve maintain their ability to move the forehead. On the other hand, if you have a lower motor neuron lesion, you lose complete innervation to both the forehead and the rest of the face, and the entire face on that side cannot move. So problems with the facial nerve give facial droop, and I've summarized them for you here. If you have upper motor neuron damage, say from an MCA stroke, the upper face will remain intact because of dual supply, but you will have lower facial droop. On the other hand, if you have lower motor neuron damage, the whole half of the face will be affected. So other signs of a facial nerve palsy, you will lose the corneal reflex. The motor portion of that reflex is carried out by the facial nerve. You will lose taste to the anterior 2/3 of the tongue. The anterior and posterior portions of the tongue have taste innervation from different cranial nerves. And then finally, you'll get a very peculiar symptom called hyperacusis. There is a very tiny ear muscle called the stapedius muscle. It's the tiniest muscle in the body, and it stabilizes the stapes bone in the inner ear. If this muscle gets paralyzed from a facial nerve palsy, the patient will be unable to tolerate sounds because they will be so loud. This is called hyperacusis, and you should remember that because it's a pretty classic board question. You may have heard of the term Bell's palsy, and a Bell's palsy is an idiopathic mononeuropathy of cranial nerve 7. And the patient presents with facial paralysis. It usually resolves in a few weeks to months. It's thought to be due to herpes simplex virus 1 induced nerve damage. There are other causes of a cranial nerve 7 neuropathy. These are technically not Bell's palsy, although people will often call them Bell's palsy if the patient has facial droop on half their face. So Lyme disease and tumors and strokes can all give you an isolated cranial nerve 7 neuropathy. The vestibulocochlear nerve is cranial nerve 8. It's sensory. It's responsible for equilibrium, balance, and hearing. It's got two distinct portions. The vestibular portion is responsible for compensatory eye movements. Lesions here cause vertigo, nystagmus, and disequilibrium. And the cochlear portion is responsible for hearing, so lesions here cause tinnitus, which is ringing in the ear, and hearing loss. And I talk about the vestibular portion in the module on vestibular system, and I talk about the cochlear portion in the module on hearing. Testing of the vestibular portion is rarely done except in unconscious patients in the ICU. One way to do this is through what's known as doll's eyes testing. To do this test, the patient's head is rotated from side to side while you hold the eyelids open. Remember, this is an unconscious patient. A positive doll's eye test means that the eyes stay fixed forward and do not turn with the head as you move it side to side. This indicates that both cranial nerve 8s are working. A negative doll's eye test means the eyes move from side to side as you turn the head, and this indicates lesions of cranial nerve 8. Another way to test cranial nerve 8 function in an unconscious patient is to inject cold water into one ear. This will disrupt the cranial nerve 8 vestibular function on that side. The way you can think about this is your eyes are kept centered because cranial nerve 8 on one side pushes in this direction and cranial nerve 8 on the other side pushes in that direction. So if you inject cold water, you disrupt the function of cranial nerve 8 on one side, and so the other side will keep pushing and the eye will move slowly in this direction. The cortex will then recognize that movement and draw it back quickly in the opposite direction. So what you should see if cranial nerve 8 is working is slow movement towards the cold water side, then rapid correction to the opposite side. That's the normal response. Slow toward, then fast away. If cranial nerve 8 is not working, there will be no slow movement toward the side you inject the cold water. And then also you can have a cortical problem, and if the cortex is not working, you will see the slow movement towards the side with the cold water because cranial nerve 8 is working, but you won't see that fast correction away. You can also conduct this experiment on cranial nerve 8 by injecting warm water into one ear. Warm water stimulates cranial nerve 8 function, and it creates relative opposite side cranial nerve 8 dysfunction. So injecting warm water into one ear is similar to injecting cold water into the opposite side. So what's going to happen is the eyes are going to move slowly away from the warm water side and then have a rapid correction back towards that side. The normal response in the case of warm water is slow away, then fast toward. If cranial nerve 8 is not working, there will be no slow movement away, and once again, if the cortex is not working, you will see the slow away movement, but no fast correction back toward the warm water side. And so many people remember the response to cranial nerve 8 testing by the mnemonic COWS, which stands for cold opposite warm same. This is named for the side of the fast correction, and it's just an easy way to remember the expected outcome from injection of cold or hot water. Cranial nerve 9 is the glossopharyngeal nerve, and it's got both motor and sensory functions, so it provides taste and sensation to the back of the tongue, the posterior 1/3 of the tongue. It also plays a role in swallowing. Now, many of your swallowing muscles are innervated by the vagus nerve, but some are innervated by the glossopharyngeal. It helps you salivate by innervating the parotid gland, and then it receives information from the carotid body and sinus, which is how the body perceives your blood pressure and responds through the autonomic nervous system. And then finally it innervates a muscle called the stylopharyngeus, which elevates the pharynx. So a glossopharyngeal palsy will lead to loss of the gag reflex, you will lose taste in the back of the tongue, and then you won't have sensation to the upper pharynx and tonsils. In addition, there will be hemodynamic effects, so this will trick the body into thinking there's low blood pressure because no sensory information is coming through the glossopharyngeal nerve, and the body will respond by increasing heart rate, raising blood pressure through vasoconstriction. The vagus nerve is both motor and sensory. It gives you taste from the epiglottis. It allows you to do swallowing, so if you have dysphagia in a board question, that usually means a vagus nerve problem. It elevates the palate. It keeps the uvula midline inside the throat. It's responsible for talking, coughing, and then it also innervates the autonomic system in the aortic arch, the chemo and baroreceptors that help maintain blood pressure and heart rate. If you have a lesion of the vagus nerve, you'll get hoarseness, dysphagia, which is difficulty swallowing, and dysarthria, which is difficulty speaking. You'll lose the gag reflex. There'll be loss of sensation in the pharynx and larynx. The palate in the back of the throat will collapse on the weak side, so one side will be higher than the other, and the side that's lower has the vagus nerve lesion, and the uvula will deviate away from the affected side. There are also hemodynamic effects of vagus nerve problems. You'll get unopposed sympathetic stimulation of the heart. The vagus nerve provides parasympathetic stimulation to the heart, and it blunts the sympathetic stimulation. If you cut the vagus nerve, the sympathetic stimulation goes haywire and you get high heart rate. You can test the different cranial nerves in a patient by asking them to say certain things. So when patients say ka, 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 this makes them raise the palate and test cranial nerve 10. If you make them say me, this tests cranial nerve 7 because they have to move the lips. And if you make them say la, 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 that's cranial nerve 12. They have to move the tongue. So just be aware of these. They can come up in board questions. The recurrent laryngeal nerve is a very important branch of the vagus. It ascends toward the larynx between the trachea and esophagus in a place called the tracheoesophageal groove. On the right side of the body, it loops around the right subclavian, and on the left side, it loops around the aortic arch. And I have a picture over here of the recurrent laryngeal nerve coming off the vagus, going under the aorta, and then coming back up to innervate the throat. If you get compression of the recurrent laryngeal nerve, you will get hoarseness, and there are some anatomic structures that classically do this. So a very dilated left atrium, like in mitral stenosis, can give you hoarseness through compressing this branch of the vagus nerve. An aortic dissection can enlarge the aorta and also compress the recurrent laryngeal nerve. Vasovagal syncope is the most common cause of syncope or fainting, and what happens is in certain people, for reasons we don't understand, some things can trigger the vagus nerve to activate, and it will increase its parasympathetic outflow. This will lower the heart rate and lower the blood pressure, and the patient will pass out. There are many triggers: hot weather, prolonged standing, pain, the sight of blood. If you've ever seen a movie where some elderly woman sees blood and passes out, this is the mechanism. It's vasovagal syncope. Cranial nerve 11 is the accessory nerve, and it's motor, and it's what's responsible for turning your head and shrugging your shoulders. And to shrug your shoulders, you need two muscles that are supplied by the accessory nerve, the sternocleidomastoid and the trapezius. If you have a palsy of cranial nerve 11, you'll have difficulty turning your head toward the normal side because that's done by the sternocleidomastoid muscle, and you'll have shoulder droop on the affected side. Last cranial nerve is cranial nerve 12, the hypoglossal nerve, and this is motor to the tongue. So if you have a palsy of cranial nerve 12, you get protrusion of the tongue toward the affected side. You can think of the two cranial nerve 12s as pushing the tongue to the midline, so if you lose one of them, the other one pushes it toward the affected side. And that's what I've written here. The opposite side pushes the tongue away unopposed. Let's review the cranial nerve reflexes. So the corneal reflex is when you touch one eye with a Q-tip and both eyes blink. It's sensed by the V1 branch of cranial nerve 5, and cranial nerve 7 is responsible for both eyes blinking. Lacrimation is when your eyes water in response to debris or irritation, so the V1 branch also senses that, and V7 is also important for tearing. You're sometimes asked about this, but if you cut the V1 branch, you won't get reflex tears in response to irritation, but you can have emotional tears because they come through a different mechanism. The gag reflex is when you touch the back of the throat and the patient gags. Cranial nerve 9 senses this, and cranial nerve 10 is responsible for the motor gag reflex. The jaw jerk is where you place your finger on the patient's chin and you tap your finger. The jaw will jerk upwards. This is done by cranial nerve V3. It both senses and sends out the jerk, so it's a trigeminal nerve test if you do the jaw jerk reflex. And then the pupillary light reflex is where you shine the light in one eye and both eyes constrict. Cranial nerve 2 senses the light and cranial nerve 3 constricts the pupil. So let's review the tongue because it has a complex innervation. So motor to the tongue is largely through the hypoglossal nerve, cranial nerve 12. And a lesion causes the tongue to deviate to the affected side. The one exception is the palatoglossus muscle, which is supplied by cranial nerve 10. General sensory information like pain, pressure, temperature, and touch for the anterior 2/3 of the tongue comes from the trigeminal nerve, the mandibular branch, which is V3. The posterior 1/3 comes from the glossopharyngeal nerve, cranial nerve 9. And then the root of the tongue actually has general sensory information through the vagus. In terms of taste, the anterior 2/3 of the tongue comes through cranial nerve 7, the posterior third comes through the glossopharyngeal nerve, and then finally the tongue root and the larynx and the upper esophagus, all this gets taste information through cranial nerve 10. And there's a structure in the tongue that you can see in the anatomy lab called the terminal sulcus, and this separates the anterior 2/3 from the posterior 1/3. In order to reach the structures that they innervate, all of the cranial nerves have to exit the skull. So let's talk about where they do that. Cranial nerve 1 exits through the cribriform plate. And if you look over at this picture of the skull on the right, the cribriform plate is right here in the anterior cranial fossa. And only cranial nerve 1 exits through the anterior fossa. Cranial nerves 2 through 6 exit through the middle cranial fossa of the skull. So cranial nerve 2 goes out the optic canal, and that's easy to remember because it's the optic nerve. Cranial nerves 3, 4, the V1 branch of the trigeminal nerve, and cranial nerve 6 all exit through the superior orbital fossa. They are all traveling towards the eye, where they innervate either the muscles of eye movement or in the case of cranial nerve V1, they innervate sensory to the cornea. The V2 branch of cranial nerve 5 goes out through the foramen rotundum and the V3 branch through the foramen ovale. In the posterior fossa of the skull, cranial nerves 7 through 12 exit. So cranial nerves 7 and 8 exit through the internal auditory meatus. Cranial nerves 9, 10, and 11 all leave through the jugular foramen. The foramen magnum, which is where the brainstem exits the skull, is where cranial nerve 11 also exits. And then finally, the hypoglossal nerve exits through the hypoglossal canal. And that concludes our module on the cranial nerves.